Good morning, students. My name is Amandeep Kaur. Today's my topic is PMS. That is प्रीमेंस्ट्रुअल सिंड्रोम। प्रीमेंस्ट्रुअल सिंड्रोम में क्या होता है कि जब मेंसेस आने होते हैं उससे 7-10 दिन पहले ना जैसे क्रैम्पिंग होने लग जाती है, पेन होती है, बैक पेन होती है, हेडेक, मूड स्विंग्स, ये सिम्टम्स शो होते हैं ना। अब इसको डिटेल में पढ़ेंगे। Premenstrual syndrome is a cyclic cluster of behavioral, emotional, and physical symptoms that occurs just prior to menstruation, that is in the luteal phase of the menstrual cycle. There is a cyclic appearance of large number of symptoms during the last 7 to 10 days of the menstrual cycle. इसमें क्या होता है, क्रैम्प्स होंगे, एब्डोमिनल पेन, लोअर बैक पेन, मूड स्विंग्स, स्ट्रेस, हेडेक, एक्ने, कई पेशेंट्स को पिंपल्स भी हो जाती हैं अगर पीरियड से 2-4 दिन पहले। पैथोफिजियोलॉजी, द probable causes of conditions are alterations in the level of estrogen and progesterone starting from the mid-luteal phase. Neuroendocrine factors such as decreased synthesis of serotonin and withdrawal of endorphins during the luteal phase. Psychological and psychosocial factors producing behavioral changes. Clinical features: abdominal bloating, breast tenderness, swelling of extremities, depression, anxiety, insomnia, restlessness, decreased concentration, increased appetite, palpitation, nausea, tiredness. Treatment is aimed at alleviations of symptoms. Since PMS is not a disease, no single treatment may be effective. Drugs like tranquilizers, diuretics, and antidepressants are used based on individual needs. Modify diet, increase exercise, alleviate stress, changing activities of daily living. Dysmenorrhea. Dysmenorrhea is a painful menstruation or cramping during menstruation. Typically, dysmenorrhea begins up to 48 hours before onset of menstruation and resolves within 2 to 4 days of onset or by the end of menstrual period. Dysmenorrhea can be classified as primary or secondary. Primary dysmenorrhea क्या होता है? Primary dysmenorrhea is one where there is no pelvic pathology, usually occurs within 1 to 3 years of menarche. Causes: painful uterine contractions stimulated by prostaglandins produced by endometrium during menstruation. Symptoms: sharp intermittent suprapubic pain radiating to the back or thigh, headache and backache, fatigue, dizziness and syncope, GI symptoms, nausea, vomiting and bloating. Treatment: non-steroidal anti-inflammatory drugs, NSAIDs, started 1 to 3 days before the onset of menstruation to decrease prostaglandin production. Oral contraceptives to decrease endometrial proliferation and production of prostaglandins. Secondary dysmenorrhea. Secondary dysmenorrhea is painful menstruation resulting from a pathologic process. The pain may be related to increasing tension in the pelvic tissues due to pelvic congestions or increased vascularity in the pelvic organs. Causes: chronic pelvic infection, pelvic endometriosis, pelvic adhesions, uterine fibroids, endometrial polyps. Symptoms: dull pain situated in back and front. Pain starts 3 to 5 days prior to onset of menstruation and relieves with the starts of the bleeding. Treatment involves correction of the causes. The type of treatment depends on the severity, age and parity of the patient. Dysfunctional uterine bleeding. Dysfunctional uterine bleeding is abnormal uterine bleeding without any clinically detectable cause. It occurs most commonly in premenopausal women. Causes hormonal abnormalities such as anovulation, pelvic inflammatory disease, endometriosis, neoplasms. Pathophysiology. Abnormal bleeding is probably due to local causes in the endometrium. There is disturbance of endometrial blood vessels and capillaries and coagulation of blood in and around these vessels. These are probably related to alterations in the ratio of endometrial prostaglandins, which are delicately balanced in homeostasis of menstruation. Clinical manifestations or signs and symptoms. Polymenorrhea, frequent menstruation, oligomenorrhea, menorrhagia, excessive and prolonged menstruation. Investigations. History of the nature of menstrual abnormality, internal examination including speculum examination, blood test, hemoglobin, CBC, platelet, PTI, bleeding time, and thyroid function test, ultrasound and color Doppler, endometrial biopsy. Management journal. Correction of anemia by diet and blood transfusion is required. Oral contraceptives for menstrual cycle regulation. NSAIDs to reduce the amount of menstrual bleeding. Antiprogesterone, mifepristone to inhibit ovulation, induce amenorrhea and reduce myoma size. Hysterectomy is done when abnormal uterine bleeding can't be corrected by conservative treatment. Cryptomenorrhea. Menstruation occurs but there is obstruction to the outflow of blood. Specifically, the endometrium is shed but a congenital obstruction such as vaginal septum or on part of the hymen retain of the blood. A patient with cryptomenorrhea will appears to have amenorrhea but will experience cyclic pain. The condition is surgically corrected. Causes congenital imperforate hymen, acquired vaginal atresia, cervical stenosis. Clinical manifestations or signs and symptoms: uterine cramping, lower abdominal pain, urinary retention, a large bulging mass felt on rectal examination, headache, giddiness. Management. Cruciate incision of hymen and drainage of blood, dilation of cervix in stenosis.